I'm the one who's making sure actually the medications are reconciled. I'm the one who's putting in the orders. I'm fortunate to have an amazing scheduling team, but it requires this closed loop communication. There's so many things that every patient needs. It shouldn't be on my patient to have to ping me to make sure everything is on track. Can we, with these tools, figure out like who's the patient, who's 45, who's eligible? But
exactly.
A 45-year-old who has like a strong family history needs to get bumped in line over maybe the 45-year-old who has no family history. Someone has to think to bring that patient for review.
I wanted to kind of ask you if you can kind of walk us through your workflow.
Yeah.
And how does it break down? Welcome back to my conversation with Dr. Aparna Parikh, Medical Director of GI Oncology at Mass General Brigham. Today, in part 2 of our conversation, we get into the details of her own workflow, what it actually looks like to prepare for a complex cancer case, coordinate across multiple surgeons and tumor boards, and keep patients from falling through the cracks. We also talk about when it makes sense to trust AI tools to act with some autonomy, and the uncomfortable question of whether technology could widen the gap between well-resourced patients and everybody else. But first, we wrap up our talk on competitive enrollment in clinical trial matching and why it can have some real consequences for some. Let's get back into it.
So there's this idea of competitive slots or competitive enrollment. And so what that means is that patient places are not necessarily reserved for each site. Instead, what happens is sites are effectively in a little bit of a race to enroll patients at a speed, right? So I have given this feedback even to sponsors in the past where if you get an email about a slot availability and you're in the middle of a visit with another patient, by the time you have come out from that visit, whoever saw that email first from another may have gotten that slot for the patient, right? And like for biopharma, I think they are incentivized to get the product to market fast, right? Get their trial timelines down as quickly as possible. And so I don't necessarily, and I definitely am not making a blanket statement that's saying that every biopharma doesn't care about equity. I think there's a lot of, there's a lot of people at, certain biopharma that, care. But I think ultimately, who are they responsible to? Their board, their shareholders, and efficiency on their end matters. And so like, how is that a system that actually makes any sense in terms of being patient-centric? That kind of example just drives me a little bit nuts. And again, you can imagine if there was a commitment or a mandate from the kind of public sector to kind of ensure that this even competitiveness or kind of slot distribution was done in a, you want to maintain efficiency, but, equitable way. Like, could you figure out a system where every patient in the country who needs a clinical trial for a particular alteration, for example, is in a system and there's some triaging of who needs it sooner versus later rather than just first come, first serve. And then that national kind of pool gets tapped into once availability is ascertained. And then you kind of map out in a fair way, patients to trial. I know that's not an easy task by any means, but even that piece around that I was just mentioning, the triage, right? So I think the other model I was just alluding to around just first come, first serve is patients that, and this may be where you need that, again, human component is there's a patient with stage 4 pancreatic cancer, stage 4 colon cancer can have very different biology in terms of how they're doing. And so like part of my job is if I even have a first come, first serve wait list is to look at that list and say, who needs it now versus who needs who can wait, right? And if we have something now, how to do that. I think the other thing that, when you're asking what could help me in particular, is I see a lot of one-time consults too, of patients that are coming for me to get that kind of pulse check around what's happening, what's coming. We may not have anything available now, but outside of like a Word, PHI protected like Microsoft doc that I kind of keep, that doesn't seem like the best use of my time either, to kind of every time a slot becomes available, go through that list of patients that and again, when it's competitive, if I saw that patient 2 months ago and then a trial became available now, I don't know quickly what's happened to that patient in 2 months because they're getting treated somewhere else. And so the inertia for me too would probably be like, I'm just going to default to the patients I know and I see regularly. So what I tell my patients who are second opinion or coming in is just ping me regularly on the gateway to get updates, because the people that are front and center a little bit more are the ones, for better or for worse, are like maybe more likely to get the slot. And that's not fair, right? That's
Yeah.
not equitable care. But I don't have the
Yeah.
bandwidth or the ability to keep track of everyone who I've ever seen anywhere, where they may be on their care journey if I'm not taking care of them.
Yeah. I might be biased just because like my background is in data, but when I hear things like this, where my mind immediately races to is that this is kind of just a big data problem, right? A lot of this information is kind of held, within all of these oncologists, individual workflows or individual heads.
There's all these firewalls for sharing, right, in the
Yeah,
US.
there's firewalls for sharing, but I would say even then, like, as a company that works in clinical documentation, I think that there's a huge variance in the quality of documentation that's being prepared by, from oncologist to oncologist. Not even because they're like missing the wrong things, or they just have different ways in which they're formatting the information, the different, things that they think are important or what they remember from these conversations. And I think that's where I see kind of this huge opportunity and, excitement from, the things like what we're building is because I think when I think about this big data problem, one opportunity that I see is that we can kind of create this latent space of information that's being kind of harvested from the very root of where the source is, right? These conversations, and if we could kind of pull these conversations and say, hey, like I can have a database of everything that every patient has ever said to Dr. Parikh and everything that Dr. Parikh ever said back to him or her, and we're able to kind of use that latent space to be able to build applications that you're talking about, right? Like, okay, if we needed to find the optimal order of patients to accrue onto this clinical trial, how do we do that, rather than just saying, hey, let me ask Dr. Parikh, and she can just, there's a lot of recency bias there where Dr. Parikh is just thinking, okay, who did I see last, or who pinged me last, right? It's really about how can we use the information that we have to make the best decisions. And I think that's what AI is good for today.
Yes,
So,
totally. Yeah.
Dr. Parikh, I wanted to shift gears a little bit, and I wanted to kind of ask you if you can kind of walk us through your workflow and what exactly your workflow looks like when you're preparing for a complex case. How does it break down, right? Because I think when people like that are builders, we think about, like I said, it's like the best case scenario where it's this easy patient and you follow this guideline and you put in all their path reports and their data and it tells you exactly what to do. But can you walk me through your workflow, and specifically for maybe a patient that doesn't fall into just the perfect guideline, and
Yeah.
how does it break down?
I think the particular example may be, let's take a patient that might be, so in colorectal cancer, stage 4 colon cancer, there are opportunities for surgical approaches that can still cure patients. So you get a second opinion, or you're getting a new patient that is coming in. I think workflow looks like you are pouring through, the night before the visit, medical records to try to piece together the story, figure out what information may be missing. Then kind of going back to the scheduling team to start ensuring that the pieces that are missing, the ball is rolling to start getting those information. Then you kind of meet with the patient, you fill in the holes, and then you start to corral your teams, right? And it might require a liver surgeon, the colorectal surgeon, the belly abdominal surgeon. You take that same patient and you might present them at two or three different tumor boards because not every subspecialty that is needed to care for that patient is at every single tumor board. Then you, as the kind of quarterback of that team, you collate that information and then circle back to the patient with the plan. And that plan can only be enacted, and you'll see this, right? Even in the NCCN guidelines, you'll see many branch points that basically suggest multidisciplinary case review. And multidisciplinary case review kind of happens in many different ways. And, one of the things that we're really working through within the colorectal cancer program at the Mass General Brigham Cancer Institute now, with our not just our downtown sites, but our entire network, is how can we ensure that every patient is getting that same review of their case as the patients where the kind of subspecialist lie. And that is also an equity kind of issue because you may not even know that that patient could be eligible for particularly, curative intent surgery because you don't have that expertise necessarily
Mhm.
yourselves to even know to refer. So we're trying to think through like, how do we ensure that kind of every patient at least gets a review of their care that gives them a thumbs up, like you're on track, stay locally to get your care, or wait a second, like, have you thought about X, Y, or Z? And let's ensure that the specialists are even looking at your case. And so it's a little bit of this problem of even like you don't know what you don't know. And so
Mhm.
even for multidisciplinary review, like someone has to think to bring that patient for review. And so are there kind of characteristics or kind of phenotypes of patients that you could train technology to say, hey, like this patient actually could be eligible for X, Y, and Z, even standard of care, let alone trials. And let's make sure that that patient is kind of brought to the subspecialist for review. Because if they're not, then you're not even going to know that that patient is even out.
Yeah. Yeah. Where do you think the biggest, bottleneck or breakdown is? Is it in kind of like the information or retrievals area where too much time is being spent on figuring out what's missing, coordinating the teams on trying to, get the missed test or, putting in the right orders? Or is it more kind of like on the information digestion phase where you're on the treatment selection area? Like,
From my perspective, like I think once you have the information, I think giving that like this is a space I'm very comfortable with, the synthesis and execution is not the hard part. It's getting the information. And then, I mean, to give you a sense of my workflow, even once I'm with the patient, and I've gotten better at using some of the ambient documentation tools in my own clinic. I'm still learning how to be more efficient in those and train them in a way that is like helpful and kind of time saving rather than time adding. But for any particular patient I'm seeing in clinic, I then have to ensure, I'm the one who's making sure actually the medications are reconciled. I'm the one who's putting in the orders. If they require certain testing, like genetic testing, somatic testing that requires physician consent, I have to do that. And then I have to put in the orders and then kind of inform with, whether it's Epic or email to the teams to make sure that everything happens. And I'm fortunate to have a amazing scheduling team, but it requires like this closed loop communication. And there are patients that sometimes we put in X, Y, and Z, and then it actually doesn't. They get lost somewhere in the system, right? They need their port,
Hmm.
they need their testing, they need their labs. There's so many things that every patient needs. And again, I will tell a patient if I'm seeing them on Wednesday, say if you don't hear back by Friday, just ping me. Um, but that again, like that's it shouldn't be on my patient to have to ping me to like make sure everything is on track. And again, I'm very fortunate that I have a very good team, but um, I've it, I've been in scenarios, where it hasn't worked as efficiently, and it's challenging.
Yeah. I mean, I think the next phase that we're going to start seeing is really kind of this wave of agentic workflows being able to kind of telegraph what needs to be done after you've selected therapy or you've already kind of made that decision, and being able to kind of go out and try to do these things in real time and be able to bring that back to you immediately and surface any issues that might arise, right? Like I've heard instances while like, wow, like had I known that it would have taken 3 weeks to schedule the appointment with the specialist, I would have changed my approach to for this patient. And so I think the next kind of aha moment that we're going to see is not just being able to leverage large language models to be able to kind of do kind of this point in time analysis or summarize or synthesize data. It's about using these large language models to build agentic workflows to kind of telegraph the next best action, try to do those next best actions, and then bring that back to you in real time so that you can just double check that those instances where those patients would have fallen off had you not known that information, that you would be able to kind of reconcile that in real time.
Yeah, and I mean, you made an interesting point about like someone saying I might pivot and change their care plan, but like, what if that provider that was booked with other patients like needed this was a better care plan in a more efficient way for
Yeah,
this patient?
exactly.
What I see a lot, like, and I get it, like because a cancer diagnosis is so upending for any person navigating it, but there's the there's a lot of anxiety management you have to do because
Mhm.
everyone wants their care and treatment yesterday and they want to see the specialist ASAP. And so like are there kind of systems and workflows that kind of help, and it has to be there has to be some of that kind of hand holding and management with the patients to kind of alleviate the anxiety if it is not something that clinically you feel like needs to happen tomorrow. But, for my own workflow, if there is something that needs to happen tomorrow and that provider in the scheduling system is not able to see the patient, that's where you phone a friend, right? And that's not the most efficient way to do it either. Is then you're saying, "Hey, like I know you're triple booked tomorrow, but I really need your help to get this person in." And whereas this person, I think we can wait a little bit. So there may like I think also this health systems of even thinking of how you triage patients into visits. Obviously, you need a critical number of providers, but can we be smarter about even triage?
Yeah.
I think the other example I use of that, I think where the triage systems could be really helpful is colon cancer screening, right? So if you look nationally, there's like a backlog of just endoscopist and availability of screening patients for colon cancer, let alone patients who have a cancer diagnosis and need their cancer or their colonoscopy surveillance. Can we, with these tools, figure out like who's the patient, who's 45, who's eligible, but
Exactly.
a
Yeah.
45-year-old who has like a strong family history
Mhm.
needs to get bumped in line over maybe the 45-year-old who has no family history, or anyone who has symptoms needs to get bumped in line versus someone who is asymptomatic and are just getting screened versus what's called a diagnostic. And I think our triage tools like, the Epic and other health systems have ways where, you can click boxes to kind of suggest, what some of
Yeah.
those things are. But, ultimately who's scheduling it, right? It's schedulers that may not necessarily have the knowledge, nor should they be, to look at that risk profile. It's not their job to triage, right? And figure out order. I think their job is to schedule, and they may have some basic parameters, but can we help with that triage in a more efficient way? Is another I think good example of how I think technology tools may be able to help.
Yeah. I think to me, it comes down to trust, right? And trust in these technologies. What we're saying, especially in other industries with this technology, is when you have that level of trust to be able to, allow the technology to execute actions, um, without like this human involvement, being required at every step. That's when you really just start seeing these kind of stepwise gains in efficiencies, or being able to kind of do this mass coordination that you're talking about. I think one risk that is beginning to emerge is with kind of the advent of a lot of these new AI tools. What's happening is you're starting to see kind of just like more flags, right? Like, hey, like this AI tool detected something and someone needs to review it. And without the trust,
Right, right.
sorry, you're kind of going into the scenario where you're just getting overloaded with these flags. And I think we have to start thinking about trust, because if these flags come with a very high degree of confidence, and it's a relatively low stake thing to do. When do you start kind of allowing these tools to be able to have discretion over, I would say, like a scheduler, and being able to decide what patients get seen in? Right.
Totally.
Right.
And again, that feels very like scary and unsettling to say, like, I'm gonna I'm gonna just trust, like you said, that tool to run with
Yeah.
it. You probably need to create that. It's interesting because you don't want to get, I think, necessarily beholden to everything needs a certain level of like evidence. I mean, what is the level of evidence that is needed um, to feel good about that, beyond, I think every system was going to do their due diligence, but kind of what is
Yeah.
the level of evidence you're going to need to feel comfortable in that. I think the other thing that is, and goes back to the public private model, is, what are the kind of federated models of data sharing? I think patients, communities, families, smaller practices really need to have a say in how the technology is probably designed, evaluated, governed, like rather than decisions being held solely by the kind of developers. Um, I think. I think you see this even in the larger AMCs too. Like, how do you and what is the fit? Like, you don't want to necessarily have everything. You have to have some fit for purpose for your patients and your health system. But you want a system that is going to recognizing that these tools change. You can't necessarily be working with 8 different AI partners that are each offering, a suite
Yeah.
of services, and you do your best guess probably around which suite of services is needed now. But what happens when things change, because the investment is a lot. And so I think, I worry a little bit about just how much like noise there is in this space right now, and like trying to get clarity around, what are the tools that are going to be most effective now, but also be nimble enough. And then again, just this, almost democratization kind of question that I think will continue to come up too.
To me, again, it goes back to trust, right? Like, I think you're starting to see organizations that were really quick with the trigger on adopting these new AI tools. They end up, having many AI vendors that they're trying to work with and juggle with. But I think what we're starting to see now is that, um, the power of AI is to be able to create this latent space with some of the data that the models are getting, and using that data to create multi-use case applications. And if you're just having one vendor for every single use case, you aren't able to kind of capture the value of kind of like the shared data model that we kind of talked about. And the other point around governance, it's a very difficult problem to answer. We've had a lot of conversations on this podcast in that the technology is changing so rapidly that it really requires a new governance structure, because traditionally, if it takes 6 months to get just even a technology to a pilot, by the time you've kind of started your evaluation to the time that you've actually finished your evaluation, the entire technology landscape could have completely changed.
Totally.
And so, there's a new governance structure that's required. And I think the important kind of learning there right now is we're at such a massive kind of sea change with technology that we need to think critically about, like, what is the guiding principle of doing a lot of these things in the first place, right? With a lot of these AI tools, what are they being compared to, right? Like, I think a lot of these AI tools, they're being compared to, best in class, right? We need like 99.9% accuracy. But really, if you compare that to a human performance, right? Like, is the models, or are these technologies able to perform better than the everyday doc, right? The doc that wakes up at 6 a.m. on a Monday after they had an argument with their spouse on Sunday. Are they going to be perform better than, it's just, there's a lot of these people factors that aren't considered, that I think technology sometimes is held to a higher standard than the everyday doc, that I think is really limiting our ability to test and iterate and kind of grow these solutions, at the bedside. So.
And good. I mean, I think the last comment here is like going back to the trust piece that as you were just talking to is like, if certain tools are framed as like good enough for the majority of people, then like I feel like this risk of potentially then again thinking about the disadvantaged groups where the wealthier, more resource patients still retain that more access to time intensive human delivered care. And we say, this tool is probably good enough. But, do you like continue to have a care delivery gap and a quality gap? I don't know the answer to that question, but as you were talking,
Yeah.
to something that was spurring a little bit.
And I think it brings a new dynamic into it, right? It's not just about the patients, right? It's about the doctors. If you have a patient with high access, but when they have an oncologist that is unwilling to adopt these AI tools, are they worse off than a patient with low access with a doctor that's.
I think really, I mean, we're also I think it can be so helpful as I find it incredibly humbling to, like, I feel lucky in a sense that I get to hyper specialize. Like, I don't envy the generalist, right? And it's so easy to like Monday morning quarterback and say, like, why didn't you think of X, Y, or Z when you come to kind of see me? But like, how can you expect people to just keep up in the community practices with the tremendous information growth that is happening in oncology across solid tumors? So
Well, Dr. Parikh, I know we're almost up at time. I wanted to ask you one final question that I like to ask every one of our guests. What is one thing that you wish kind of technologists, really understood better that they don't today? And then also vice versa. What do you really wish kind of your peers understood more about technology that, I think would help kind of accelerate the adoption of AI in oncology?
I mean, maybe I'll take that second question first. I think even for myself is the trust and a little bit of the fear of what technology can and can't do. And I think that fear comes from probably just lack of understanding. I am not in the AI space at all. And any potential change in workflow when you're really stretched already can feel a
Mhm.
little bit unsettling. And so I think there's a bidirectional need for knowledge exchange, even with the providers who may not be as informed around this space. So I think that technology developers, I think, really need to understand the challenges that clinicians face and like articulate very clearly how um, their solutions are directly helping with those challenges because I think otherwise there's just this little bit of that trust piece is going to be so critical for broad implementation and deployment of these tools. And because if you're not able to engender that trust, and that trust comes from again conversations like sitting arm to arm with that clinician, understanding what the problems are without knowing that, you're not going to be able to engender trust. And so I think really getting in there in terms of problems that the both community oncologist, academic oncologist, oncologists in low and middle income countries are facing, hearing those, and then kind of really articulating clearly how kind of solution A, B, or C is going to help mitigate that. And then the follow up piece to kind of show how the solution actually did or did not. Um, and I think owning the limitations too. I find sometimes you get a little bit oversold sometimes on what things can and can't do. And so I think that honesty and integrity piece and recognizing like what can be done today versus what might never be able to be done versus like we're not there yet, but in a couple of years we're gonna get there is gonna be important.
I couldn't agree with you more. I think, one of the most important lessons that, I've learned, building this company is, the best technology doesn't win. And, as a technologist, your assumption is that you just build the technology and it's going to work. But in medicine, I think the change management and, engendering that trust that we talked about is just as important, if not more important than just building the best technology.
A hundred
So I couldn't agree with you more. Well, Dr. Parikh, I know we're up at time. I really enjoyed our conversation today, and thank you so much for spending a little time with us on our podcast.
All right, take care.